We can evaluate patients with carotid stenosis through history, carotid per week, and the imaging studies. Useful information in the history are vascular risk factors, focal neurological deficit like hemiparesis, hemihypothesia, transient monocular blindness. Likely unrelated events are syncope, headache, or pain, because they are usually related to the posterior circulation, not to the anterior circulation. Carotid per week. Despite the absence of carotid artery per week may signify incomplete occlusions of the carotid artery, and the hemodynamically significant stenotic lesions may exist in absence of an audible per week. Classical recommendations assess for the presence of carotid artery per week. The sensitivity and the specificity of the carotid artery per week ranges from 65 to 75%. Evaluations of patients with carotid disease through imaging studies, carotid duplex, discussed in details by Dr. Vascular, and she focused on the velocity, B mode, and the color order, and she told us these important items with contralateral internal carotid artery occlusion, internal carotid artery flow velocity may be falsely elevated, and also she focused on, we must comment on the extent of the plaque characteristics and the patency of the distal internal carotid artery. CT angiography, good resolution, but requires good experts for interpretation. Complications usually related to intravenous dye. MR angiography also requires good experts for interpretation, and complications usually claustrophobia induced machine. The patient wants to lie still for 20 to 30 minutes. Digital subtraction angiography, one of the golden standard for diagnosis, but it carries 1% stroke risk, and also complication related to intravenous dye. In the treatments of patients with carotid stenosis, we must put in our mind two important items. The first item is to stabilize or halt the progression of the plaque. The second item is the carotid revascularization therapy. To stabilize the progression of the plaque, we must control blood pressure, diabetes, dyslipidemia, stop smoking, alcohol, and encourage regular exercise for 30 to 60 minutes at least 3 times per week. The antioxidants may play a role, as pomegranate juice consumption for 3 years by patients with carotid artery stenosis reduces the common carotid intima media sickness, blood pressure, and low density lipoprotein oxidation. The second issue in treatment is the carotid revascularization therapy, either carotid endarterectomy or carotid artery stenting. We can look to this management algorithm in the cases of external carotid artery stenosis. We must know at first, is the patient symptomatic or asymptomatic? If the patient is asymptomatic and the degree of stenosis is less than 60%, we prefer best medical therapy: antiplatelet, control of blood pressure, diabetes, regular exercise, stop smoking, alcohol cessation. But if the degree of stenosis is more than 60%, we look to the perioperative risk. If the perioperative risk exceeds 60%, it is preferred to do medical treatment. But if the perioperative risk is less than 60%, we can do carotid revascularization therapy, either carotid endarterectomy or carotid artery stenting. For patients with asymptomatic stenosis and the degree of stenosis is more than 60%, if the age is more than 79 years, The patient is unstable cardiologically, so the surgical risk is high, so we prefer medical therapy. On the other hand, if the age is less than 79 years, and the patient is stable cardiologically, so the surgical risk is less than 3%, we can do endarterectomy or carotid stenting if the patient has severe pulmonary disease, congestive heart failure, if the patient performed carotid endarterectomy and the pre-stenosis occur, if there is ipsilateral irradiation, if there is contralateral vocal cord paralysis from previous carotid endarterectomy, here we prefer carotid stenting. On the other hand, if the patient is symptomatic and the degree of stenosis less than 50%, we prefer medical therapy. If the degree of stenosis more than 70%, we prefer carotid revascularization therapy, either endarterectomy or carotid stenting. If the degree of stenosis is moderate, from 50% to 69%, we look for, again, the perioperative risk. At first, if the stenosis is less severe, age less than 75 years, female sex, stroke more than 3 months earlier, visual symptoms rather than hemispheric symptoms, so low risk of carotid stroke, we prefer medical therapy. On the other hand, if the age more than 75 years, male 6, stroke 3 months earlier, hemispheric symptoms, we can go to the carotid revascularization therapy, either carotid endarterectomy or carotid stenting. Carotid endarterectomy carries risk of MI, hyperperfusion syndrome, stroke, nerve damage, parotitis, infection, and death. We mentioned the indications of carotid artery stenting. Complications of carotid artery stenting: stroke, heart attack, bleeding at the catheter insertion site, damage to the blood vessel at the catheter insertion site, infection, pre-stenosis, and death. Carotid artery stenting, the procedure will be done in the workshop, but simply after going arch aortogram and carotid and cerebral angiogram, long access sheath placed after cannulation of common carotid artery, guide wire passed through area of carotid narrowing, and after that we place the embolic protective device, pre-stenting angioplasty, stent deployment, post-stent angioplasty, and the removal of the protection device and the guide wires and sheaths. Recommendations for carotid stenosis: carotid revascularization can be considered when the patient has had stroke or TIA, the degree of stenosis is more than 70%. Carotid endarterectomy continues to be the gold standard for treatment of carotid stenosis. With continued development of technology, carotid stenting has begun to rival the standard. Thank you.